All right, good afternoon and welcome everybody. Thank you so much for joining us today. This is the DOPPS Practice Monitor Emerging Trends update for September 2017. And thank you once again for joining us. We have a packed agenda for today, and hopefully you'll find this enlightening and informative with respect to current practice and where things are heading. Next slide, please. Okay, so I'm giving, my name is Bruce Robinson. I'm the Principal Investigator of the DOPPS program, and I'll just give a brief introduction today, and then we'll move on to the content of the hour. Doug Fuller will provide recent trends in U.S. hemodialysis practice, and following that, Dr. Jenny Shen will provide an update on our focus topic for today, which is PDOPPS, our peritoneal dialysis outcomes and practice pattern study, which we're really very, very excited about. Relatively recently launched study with lots of new data and I think a lot to show and discuss with you all. And then following that, Mark Newman from Nephrology News and Issues will provide update on U.S. policy. Once again, Mark has multiple policy issues that need to be covered. There's always so much going on. And I'd just like to give a warm thanks as well to Mark and NNI for co-hosting this web conference along with us. So thank you very much, Mark. Next slide. Just a slide with the acknowledgments with respect to supporters for the DOPPS program, all as listed here. And support for DOPPS program is provided without restriction on our publications. Thank you. And so the DOPPS Practice Monitor is a publicly available website. Please feel free to access it whenever you would like. We provide updates every 4 months, and our most recent update was at the end of August with data through June of 2017. We have many hundreds of graphics and underlying data tables for you to look at that describe really in detail hemodialysis practice and trends over time in that practice. We actually launched the DOPPS Practice Monitor just before the launch of the updated bundled payment system. So we launched this in August of 2010 in anticipation of the bundle in 2011 with updates ever since then. Okay, and we'd certainly encourage you to join the conversation. So follow us at DOPPS Study. Use hashtag DOPPS for tweets about today's presentation. And thank you so much for staying involved with us and for your interest. We also do like to keep these conferences as interactive as possible. So we welcome your questions throughout the session, and we'll pause to answer them at the end of each section. Please submit your questions using the Chat with Presenter feature, which is accessed by the blue icon at the bottom left corner of the screen. And in addition, we are going to have interactive polling throughout today's presentation. So throughout the presentation, we'll offer several poll questions about treatment practices in your unit. All of your responses will remain confidential. And when the poll is open and displays on your screen, please answer the question, and then don't forget to hit the Submit button. All right, well, without further ado, I'll pass the microphone over to Doug Fuller. Doug Fuller is a senior analyst and biostatistician here at Arbor Research, and really the lead biostatistician for the U.S. DOPPS Practice Monitor. Doug.
Thank you, Bruce, and welcome again to everybody on the phone. So these are DPM highlights from the most recent update from the end of August 2017. The data here are shown from June 2014 through June 17. These are shown every other month. As Bruce mentioned, on the DPM website, we do have data going back as far as August of 2010. But for the purposes of demonstrating the most recent data, we show the trends here starting from June 14. So the first slide here looks at vascular access and use at during each study month. And we've seen a slow but increasing trend in the proportion of patients using arteriovenous fistula. That's increased from 66 up to 69% over this 4-year period. Now, this is also showing a decline in catheter use from 15% down to 12%, which is notable. I will note a quick difference between our data and data you may know from the US RDS, which showed any catheter use upwards of 18% and fistula use 65%. There is a slight difference in the methodology in how this is calculated that may account for that difference, in the sense that the US RDS counts any catheter use as catheter, and so fistula use is fistula only, whereas in our data, patients who have both a fistula and a catheter would also be classified as fistula. Next slide. We've been tracking the uptake of Pegylated Decode beta, a new ESA on the market available in 2015, and so it's rapidly increased starting around April of 2015 and now reaching 36% of all patients in the U.S. by June of 2017. We've also seen an increase in the use of darbepoetin, which is another long-acting ESA. That's increased from about 5% up to now 20% of patients. Concurrently, the proportion of patients using epoetin alpha as the ESA for those patients, that's dropped from 95% down to less than half, 44% of patients. Next slide. Even with this change in ESA type in U.S. hemodialysis patients, we've not really observed much difference in the distribution of hemoglobin. This is among all patients, not just ESA treated and not just Medicare patients, but all patients in our DOPPS facility sample. The distribution has stayed pretty steady with median value of 10.8 grams per deciliter throughout the last 4 years. Next slide. Serum ferritin levels have increased and have been increasing throughout the entirety of the DOPPS practice monitor period. The last 4 years, of course, is shown here. From June 14 through June 17, the median value of serum ferritin has increased from 725 to 810 nanograms per milliliter, with the 90th percentile exceeding 1,400 nanograms per milliliter now. Next slide. So the first poll question that we wanted to ask is, are any patients in your facility currently prescribed an iron-containing phosphate binder, such as Auryxia or Velphoro of the brand names? And please respond yes or no, and don't forget to click the submit button. All right, so the responses are in. Looks like we had about 40 responses altogether. About 71% of you said that yes, patients in your facility, and some patients in your facility are currently prescribed an iron-containing phosphate binder, and 28% said no. So thank you for those responses. And with that, we'll show the next slide, which does show the proportion of patients overall using an iron-containing phosphate binder over the past 3 months, and this is any use in the past 3 months, even if it's intermittent. And we can see that this data is available in DOPPS 6, which began in the middle of 2015. So that's why on this slide the x-axis begins at June 15 instead of 14. And we can see that in the beginning of DOPPS 6, about 2% of patients were using iron-containing phosphate binders, but in the most recent month, in June 2017, we're up to about 7% overall.
It's interesting, Doug, hey, this is Bruce. It's just interesting to see that amongst our audience, nearly 3/4 of participants do see use of drug in their unit. And so presumably it's being used in general in a small number of patients, but in a large number of hemodialysis units. That is an important change in practice.
And we will have forthcoming perhaps some additional details about how iron-based phosphate binders are being used in our DOPPS facilities. So stay tuned for that. Turning to mineral bone disorder, we've been reporting a steady increase in PTH levels since the onset of the bundle in 2011. Over the last 3 or 4 years, the PTH levels have continued to increase, although the rate of increase is much slower than we reported before. Currently, the median PTH is 372 picograms per milliliter, with a 10th to 90th percentile distribution of 141 up to 953 picograms per milliliter. Next slide. And we note that this increase in PTH has occurred with some pretty dramatic shifts in the treatment used to reduce PTH levels. In the case of vitamin D, the blue bar represents proportion of patients using IV route vitamin D, and the orange bars represent patients getting oral vitamin D. And you can see starting in 2015, there was a pretty sharp increase, now at 33% of patients using oral therapies only for vitamin D, with another 17% using both IV and oral vitamin D. And this transition has presented a shift from IV doxycalciferol primarily to oral calcitriol that's given in the unit during the dialysis session. Next slide. So to quickly summarize recent trends in the DPM, we haven't seen any clear changes in dialysis prescription practices since 2013. That includes things like treatment time and kPOR, vascular access. Catheter use continues to decline, now about 13% in the most recent data. Mircera use has stabilized, now at 35 to 37%, with median hemoglobin levels also remaining steady. Increases in ferritin and PTH have been about 10% since 2014, observed at all percentile levels. And oral calcitriol is now used by about 50% of patients receiving vitamin D, and this increase has mostly been observed among our LDO facilities here. So with that, I think next slide, we'll open it up for questions.
Doug, one question. With the substantial increase in use of oral active vitamin D, does this seem at all related to the steady increase or a steady but slow increase in PTH that we have seen?
You know, I believe we did some studies earlier on when we were seeing a shift from IV paracalcitol to doxycalciferol, and we didn't notice any particular association between the product use within the IV formulations, between the product use and the rise in PTH. Likewise, I feel like the trend in PTH that's been increasing has been pretty steady, and in contrast to the pretty sharp change in product route. So on the surface, I wouldn't expect that to have a strong relation there.
Yeah, I would tend to agree with that as well, Doug. We and others will do additional work on that, but I would tend to agree with you that that doesn't seem to be a primary driver of this.
Now, it may also be the case that patients who are otherwise well managed and don't need the perhaps stronger treatment of the IV route may be the ones going to calcitriol. So there may be some differential within differential in PTH increase depending on who's getting what treatment.
Right. Yeah. Thank you, Doug. question. We have a question on whether any data on secondary AVF use. Also, Dr. Pisoni is here with us as well. Ron, and Ron's done a lot of work with the DOPPS over the years with vascular access. Any comments on this specifically?
Yeah, thanks, Bruce. We haven't specifically looked at that in our data in recent analyses, but it is an interesting question. I think that would be interesting to look at. So at the present time, we haven't examined this at this point, but to see to what extent that may be occurring, I think would be interesting.
Do you mean here, Ron, use of second AVFs, placement of AVF in a second location?
Right.
I think that's, yeah.
Right, yeah.
I think that's the question. Right, I agree with you, as opposed to secondary or terminal failure of a fistula. The other point that we found very interesting, and actually focus of a manuscript under review of ours, is looking at location of AV fistula, and we have noted clearly a move from lower arm to upper arm AV fistulae in the U.S., such that now it's roughly 2/3 of fistula that are placed in the upper arm. Some of these will be second fistulae, but very often actually the initial fistula will be placed in the upper arm as well. And ultimately the consequences of this are as yet unclear. So this is actually an important trend and does differentiate practice in the U.S. from elsewhere in the world. We had another question as well related to older patients and AV fistula versus catheter use. Any comments on that?
Yeah, in that regard, certainly patients who are older, and these are patients who are 75 years of age and older, tend to have a slightly lower use of AV fistulae. At this point, we haven't looked at if AVF fails in an older patient, then what is the likelihood then of going on to a second fistula or a graft compared to staying on a CVC? I think it's an interesting question, one that we would be very interested in looking at, and I think it's an important question as well. But at this point, we haven't looked at that.
Thanks, Ron, and thanks also to Doug Fuller for your overview, and thanks to the audience for your questions.